Basically, I think that because of the fact that TAF has come out in its various formulations, some people have thought maybe that the initial approach to ARV therapy is all kind of like in a clean little package. But as always with HIV, it continues to be a moving target. And I'll kind of go through a lot of data that I didn't really think about. I thought about these studies individually, but not as a group. And it helped me to think about other possible ways of treating patients. So now you have to put your thinking caps on, because there's a few questions. So this is a patient at the VA that's a newly diagnosed HIV patient who is a 48-year-old MSM. And he was tested for HIV by his primary care doctor, who's been treating him for hypertension and diabetes for 12 years. As for many patients at the VA, they have HIV as an incidental finding, and that their other problems are really the dominant problems. So in this case, they happen to be diabetes, which is well controlled, coronary artery disease, with a history of an NSTEMI, and he has, this is important, a CKD with a creatinine clearance of 25. And he reports that he's been adherent with his med follow-up and rarely misses doses of his prescribed medications, which include his diabetes medications, aspirin, metoprolol, lisinopril, and atorvastatin. In case you're interested, his lipids are well controlled and he's a non-smoker. So his CD4 count is 388. His viral load is 147,000. His HIV genotype showed K103N. And he was HLA-B5701 negative. His creatinine is 3 and his eGFR is 25. His LFTs are normal. He's Hep B immune and Hep C negative. His last hemoglobin A1C was 6.5, and his hypertension and diabetes are relatively well controlled. And he is interested in starting ARVs. So which NRTI combination would you recommend for this patient? Abacavir lamivudine, TDF, FTC, TAF FTC, or I would use lamivudine without other NRTIs, or I would not use NRTIs in this patient. So again, he has HIV, his viral load is 147,000, his CD4 is 388. He has significant kidney disease and a history of coronary artery disease that's well controlled, and diabetes that's well controlled. So I think you can vote now. TAF, okay. Anyone have any comments about why you might not want to use TAF in this patient? You mean it's approved for greater than 30?
Yes, sorry, greater than 30.
And he has such bad kidney disease. Is he the best patient to try it, and even if it's supposed to be relatively benign for the kidneys? Okay. So basically, aside from TAF, which I unfortunately didn't feel comfortable doing in this patient, I think a lot of people might have chosen D or E. A lot of people might have chosen not to use abacavir because of the CAD, even though it's well controlled. And then some people would use 3TC with another drug or 2 other drugs. And then some people would choose one of the more common regimens that we would use, which would be not using any NRTIs in a patient that has reasons, relatively speaking, to avoid NRTI use. So which other agents would you use in this regimen? So we're just going to assume that we're not going to use abacavir, tenofovir in any of its formulations. And so then if you're going to have construct an antiretroviral regimen for this patient, would you choose a boosted PI by itself, or maybe with 3TC, or an integrase inhibitor, maybe with 3TC, or a boosted PI plus an integrase, or something else? A boosted PI has plus an integrase inhibitor. And so I'll just make the point that I think a lot of us would use something that included dolutegravir and darunavir, but that there are no clinical trials to support that decision at this point. So that, like many times in the history of HIV, we make decisions in the absence of data, and then we cross our fingers and hopefully we're right most of the time. So I think I'm talking about dual therapy because we all think, like, because of the fact that TAF is out, that maybe all of our patients are going to be on something like TAF FTC dolutegravir or abacavir 3TC dolutegravir. And so there's other ways to kind of think about it. And in a global scale, one of the things that we really need to do is treat the most patients in the most cost-effective way in the context of other things like HIV prevention. So this is just to remind you the UN/AIDS fast track targets, which are to have 90 patients diagnosed, treated, and having an undetectable viral load by 2020, and that it be 95, 95, 95 by 2030. and that you can see that if we get to that 2030 goal, that we can actually significantly reduce the incidence of new HIV infections globally. And it's also just to remind you that we have faced the same problem. There was some data that was presented at CROI this year which showed that we were pretty poor about the number of patients that we had on therapy in the United States that were suppressed. And that the Medical Monitoring Project showed some data that only 37% of patients in the United States are receiving ARVs. And on a global level, about 13 million of 35 million patients are receiving ARVs as of 2013. So now we're talking about this patient who we don't want to use abacavir or tenofovir in. And this is just a comparison of the various international guidelines for what to do in this situation. And so you can see that there's two major regimens that are considered, and the regimens are considered based upon clinical trials. So the one that we would use is not recommended because there's no clinical data to support it yet. And so it's darunavir, ritonavir, raltegravir across the three, and then lopinavir, ritonavir 3TC, which is considered an alternative based, it's considered a regimen that you would use based upon the fact that there's data, but it's not a regimen that most of us would use based upon tolerability. And then the major caveat that's also made in this study in these recommendations is that it's relatively, there's much less data for patients with a low baseline CD4 or a baseline high viral load of greater than 100,000. So you'd have to show a lot more caution and follow these patients more closely if that was the case. So I just want to remind people that we have a long history of using ritonavir boosted PIs as monotherapy or studying it, and that because of the fact that the drugs have a high genetic barrier, and if they fail, you're unlikely to have any PI resistance. So there's two major ways that you can study PI monotherapy. One is in naive patients, and another way to do it is to do an induction maintenance strategy where you take people that have viral loads that are suppressed, and then you de-intensify their regimen to ritonavir boosted PI versus continuing their standard treatment. And there have been meta-analyses that have been done for both of these groups of patients that have shown that monotherapy is inferior, both in induction therapy, but also in de-intensification. So then I'll just say that one of the big themes of my talk will be, what about if 3TC is in the mix, both as an induction and also in maintenance, or in induction or in de-intensification, because we all know 3TC is, we kind of think about it like it's like something that we can put in the water because it's so well tolerated and it's such a great antiretroviral and we have so much experience with it that why not use it if it does something, and it's also really cheap because it's generic. And then there's some interest in dolutegravir monotherapy as well, which I'll show you some of the data on. And that clearly, just to do one major conclusion, is not ready for prime time. As I said, there's many ways to study dual therapy for HIV. One is in randomized trials where you compare 2 drugs to 3 drugs. And then another way to study it is to do a switch study where you take antiretroviral suppressed patients and then you randomize them to 2 drugs or 3 drugs. Or you do an induction maintenance approach, which is you achieve suppression with a 3-drug combination, and then you randomize to 2 drugs versus 3 drugs. And that another way to do it is to take suppressed patients that are currently suppressed, and then randomize them to continue their therapy versus switch to 2 drugs. And there's a lot of open label trials too, where they just look at 2 drugs as an open label trial, and it's not a comparative trial. And then I'll just make one other comment, which is that I think most people that design these studies feel that the induction maintenance approach might be the safest because of the fact that basically you maybe need a total of less ARV drugs to maintain suppression than to achieve suppression. So that means that you may get away with either a less potent regimen or you may get away with more non-adherence if the patient's already suppressed. So this is the hardest question. So for which of the following 2 drug combinations is there proven non-inferiority to a 3-drug combination in antiretroviral naive patients? And that's based upon large trials where you'd feel comfortable with the data. That means there's at least one large randomized trial in naive patients which supports the use of this 2-drug combination as compared to a 3-drug combination. So the choices are an NNRTI plus a PI versus 3TC plus a PI versus a PI plus an integrase inhibitor, NNRTI plus an integrase inhibitor, or an integrase inhibitor plus 3TC, or A, B, and C. So this is awesome, but because actually I think A, B, and C are right, And so therefore, I think F is right. So therefore, all of you are right. So these are the studies that show by class in antiretroviral naive patients, the studies that show this non-inferiority of 2 drugs versus 3 drugs. So I think I'm stretching it with ACTG 5142 because the Kaletra and efavirenz arm did slightly worse, and it was much worse in terms of tolerability. But that's kind of an ancient study. But it was the first really good study that even looked at NNRTIs plus PI-based regimens with ritonavir-boosted PIs. And then the Gardel study, which is so again, I'm going to come back to the fact that some of these studies have been done internationally and some of them have been done more in the developed world so that they may have different implications for the different populations. So the Gardel study was done in kind of like countries that are between the poorest and the richest countries. And they looked at 2 nukes plus lopinavir versus 3 TC plus lopinavir. And in that study, the 2-drug combination was non-inferior across all subgroups, including people with low CD4s and high viral loads. The modern study was an open-label, it was a randomized trial looking at maraviroc plus darunavir versus tenofovir plus darunavir. And the study was prematurely halted because of the fact that the maraviroc PI arm was inferior to the tenofovir FTC plus darunavir arm. And then there's 2 large studies that looked at the combination of PI plus integrase inhibitors, and there's more studies planned. But the NEAT 001 study was a study that showed that the PI darunavir plus raltegravir was non-inferior to standard treatment, except for the subgroup of patients with a CD4 of less than 200, and a trend for people not doing as well with a viral load greater than 100,000. And then the PROGRESS study was another large study that compared lopinavir plus raltegravir versus tenofovir FTC plus lopinavir ritonavir. So again, to review the NEAT study, which was published a couple of years ago, about 800 patients in European countries, not 15 European countries. No, it was 15 European countries. Were randomized to 2 drugs versus 3 drugs. And then the primary endpoint was a change in therapy prior to week 32 due to an inadequate response or a viral load of greater than 50. And so it was a composite endpoint that included both virologic and clinical endpoints. And so looking at the composite endpoint, the raltegravir darunavir arm was non-inferior to the TDF FTC darunavir arm. They also looked at other endpoints, including the primary endpoint of virologic suppression was also non-inferior for the raltegravir tenofovir arm, but you can see that for the subgroup of patients with a baseline CD4 of less than 200, there was clearly superiority for the TDF FTC raltegravir arm, and a trend that was looks like it was almost statistically significant in the subgroup of patients with a viral load of greater than 100,000. Another main thing to mention in this study is that in the raltegravir arm, 18 patients developed resistance mutations when they failed, and 15 out of 18 developed integrase resistance. And that was not true in the standard treatment, so that this regimen did worse in the subgroup of patients, but also was more prone to developing integrase resistance. And there are 2 other studies I'm not going to mention that also looked at the combination of darunavir and raltegravir. They were the RADAR study and an ACTG open label study, and they had similar findings. So the Gardel study is another international study where patients were randomized to BID lopinavir plus 3TC versus BID lopinavir plus investigator chosen combination therapy. And the primary endpoint was a viral load of less than 50 at 48 weeks. Approximately 80% of the patients were from Latin America. And one interesting thing about this study is that more than half the patients received AZT as their background. So again, a lot of these studies are using drugs that we don't use anymore, but at least conceptually you can see that what the outcomes of the study are, which I think are very important. So for the primary endpoint, the 2-drug combination of 3TC plus lopinavir was non-inferior to the 3-drug combination. So unlike the NEAT study, the subgroup of patients with a baseline high viral load and with a low CD4 count did just as well. And then there were more discontinuations in the 3-drug arm versus the 2-drug arm, and most of it was because of toxicity. So presumably most of it was AZT toxicity. That was one of the things that it seems like GI side effects from the AZT seem to drive a lot of the discontinuations. So then it brings us to the important question, which is like now 2 drugs versus 3 drugs do well. What would it have been like if the 2-drug combination was darunavir and dolutegravir? So that's still one of the major big questions that we want to know, is that when we have a much more potent integrase inhibitor, what would the results would have been? And then the modern study, which randomized about 800 patients with R5 HIV to Truvada and darunavir ritonavir. 2 nukes plus darunavir ritonavir versus darunavir ritonavir plus Maraviroc. And so at week 48, the virologic suppression was 77% in the Maraviroc arm versus 86% in the tenofovir FTC arm. And there were more treatment failures in the Maraviroc arm. And there were greater differences in patients with high-risk HIV, which meant high viral load or low CD4. And the study was terminated at week 48 because of the fact of the inferiority of the Maraviroc-based arm. What about in patients that are switched that have already been suppressed? So there's definitely multiple 2-drug combinations that have been studied. So in suppressed patients, you can switch them to PI plus 3TC, or PI plus NNRTI, or PI plus integrase, or NNRTI plus integrase. So going along with the hypothesis that the 3TC ritonavir boosted PI is a very promising combination, there have been 2 recent studies that, again, showed these results. One in which patients that were suppressed were switched to ritonavir atazanavir plus 3TC versus ritonavir atazanavir plus 2 NRTIs. And the OLE study, which looked at people that were suppressed on a lopinavir ritonavir-based arm after they were suppressed for 6 months, and then they were switched to 2 nukes plus lopinavir versus lopinavir ritonavir plus 3TC. So a similar design has been done with a smaller study where people were switched to ritonavir, darunavir plus rilpivirine. So going along with this possibility that the NNRTI plus the PI could also be an effective combination. I'll also point out that combination would be a lot more expensive, so that it might be less appealing in the developing world because there's 2 drugs that are on patent. And so it's not necessarily the cheapest combination. And then another study which had a negative result, which was ritonavir atazanavir plus raltegravir. So again, showing the potential bad outcomes of using raltegravir with the ritonavir boosted PI. And of course, one of the studies that we've talked a lot about, the Latte study, which was an induction maintenance approach, comparing the Latte 1, 2 different regimens, an integrase inhibitor versus an efavirenz-based regimen for induction, and then looking at a ritonavir cabotegravir combination for maintenance. So the SALT study, patients that had a viral load of less than 50 for at least 6 months, about 300 patients were randomized, and they were on various regimens to start with. So what they did with these patients was they switched them all to ritonavir atazanavir plus 2 NRTIs for 1 month. And then they randomized them to ritonavir atazanavir plus 3TC versus 2 nukes plus ritonavir atazanavir. And then they followed them for 96 weeks. And the other things I wanted to say was that in these studies, these patients were actually very well controlled because their mean duration of virologic suppression was about 40 months prior to enrolling in the study. And then the majority of them were on either tenofovir, and the majority of them were on a ritonavir boosted PI. So the results of the SALT study in this well-powered study showed non-inferiority for 2 drugs versus 3 drugs at 48 weeks. And they did a lot of subgroup analyses looking at metabolic complications. And there were more discontinuations in the 2 nuke arm than in the 3TC arm. And there was very low incidence of the development of resistance. Yes, AZT was allowed, but it was a more recent study, so most of the patients were on tenofovir at baseline. One thing about the newer studies is they're using more standard of care drugs that we tend to use. So the SALT study, OLE. So OLE was also a European study that looked at 250 patients that were randomized to 2 nukes plus lopinavir versus randomization to 3 TC plus lopinavir and continuation of 3 drugs. And then there was, again, a 45-month period of virologic suppression before the patients were enrolled. So this is important because in the developing world, like the Gardel study, it again shows this really good results with the combination of 3 TC plus lopinavir. So those are drugs that are widely available in the developing world, and so they have probably some implications for international settings. So the PROBE study was a much smaller study where 60 patients were randomized after they were suppressed to rilpivirine darunavir versus continuing 2 nukes plus a PI, and there were only 30 patients approximately in each arm. And so the rilpivirine ritonavir darunavir is appealing to us also because it's a metabolically benign combination with a low pill burden. And one might imagine one might be also interested in rilpivirine plus dolutegravir as another 2-drug combination with a low pill burden and good tolerability. And in fact, there's going to be 2 large phase 3 studies that are going to look at the combination of rilpivirine ritonavir darunavir switching after being suppressed, called the SWORD-1 and SWORD-2 studies, so that we're going to get more information on that darunavir-rilpivirine combination. And then I'm not going to go through this data, but just to tell you that this is another drug where patients that were suppressed on suppressive regimens, including a PI, it's another study that shows a negative result for the combination of a PI plus raltegravir versus standard treatment. And the study was also terminated early on by the DSMB because of inferiority and higher incidence of developing raltegravir resistance in the 2-drug arm. So here's something that we're all really excited about is the drug nanocrystals and the cabotegravir and rilpivirine being available and being studied in these long-acting nano suspensions, which allow the drug to have possible serum levels that are adequate for anywhere between 1 and 3 months with a single IM injection. And so this is actually just to review the data for the LATTE-1 study, which was recently published, where 240 patients, and this is a good example of an induction maintenance approach, where all the patients received a relatively standard treatment of either 2 nukes plus cabotegravir, which is an integrase inhibitor that's closely related to dolutegravir, versus 2 nukes plus efavirenz. And then after 24 weeks, when everyone achieved virologic suppression, then everyone that received the cabotegravir-based regimen was switched to the rilpivirine plus cabotegravir. And again, the patients are going to be followed for 96 weeks. And this is just to show the virologic suppression, which was comparable across the arms. And that in the maintenance phase, there were some failures in the 10 milligram cabotegravir arm. I think 3 patients developed resistance mutations, and 1 patient specifically developed an integrase mutation. So why this is important is that even though cabotegravir is related to dolutegravir, it looks at least like its genetic barrier is slightly lower than dolutegravir, so that you can actually develop resistance to this drug. And again, this may have implications for patients that are receiving this IM if they're non-adherent or they don't follow up, where we might be selecting integrase resistance with the long-acting agents. So that's going to be something that we're going to have to look at very closely. So again, there was comparable suppression at week 96 in the cabotegravir and efavirenz arms. There was no clear toxicity signal in the cabotegravir-rilpivirine arms. And then 1 patient developed an integrase resistance mutation 148, which would be a major mutation for raltegravir and elbaptegravir and dolutegravir. And the E138K mutation, which is a rilpivirine mutation. And then the LATTE-2 study was recently presented at CROI this year. So again, this is there were 2 major studies with the cabotegravir. One was the cabotegravir as a PrEP agent in the ECLAIR study, and then this treatment study, LATTE-2, which is this first study looking at these injectable long-acting combinations of cabotegravir plus rilpivirine. And so here the primary endpoint was, just to go through the study design again, which is patients were started as the induction phase on cabotegravir plus abacavir 3 TC. And then rilpivirine was added at week 20. So presumably rilpivirine was added, one main reason would be to assess the tolerability, because then basically if the patient has any toxicity from rilpivirine, you don't want to start them on an IM drug that they're going to have rilpivirine in their system for 3 months. And so if they developed rash or neuropsychiatric side effects, then you would be able to assess it early. And then after week 20, then they were started on 2 different long-acting IM formulations of cabotegravir plus rilpivirine. One was for every 4 weeks, and the other arm was every 8 weeks. And then a smaller group of patients were continued on the cabotegravir abacavir 3TC. And the primary endpoint for the study was that they were going to use for dose selection was the virologic response across the arms at week 32. Just to let you know that there were some virologic failures. There was 2 virologic failures in the cabotegravir IM arm that was every 2 months. And there was 1 virologic failure in the continuation of the people receiving abacavir 3TC cabotegravir. And no patients developed resistance mutations. It's suggestive that this is a combination that's of interest for future study, and that the final dosing and frequency of dosing for the long-acting maintenance study has not been determined yet. And so this is actually the primary endpoint at week 32, which showed similar virologic suppression across the 3 arms. And one of the findings was that a lot of patients complained about pain, local site reactions early on in the IM cabotegravir arms. And there was a smaller incidence of swelling and nodules, but that the incidence of people complaining about side effects from the injection site decreased dramatically from 86% on day 1 to 33% at week 32. Another thing that's worth mentioning is that they did patient satisfaction questionnaires at week 32. And what they found was that the patient satisfaction was much higher for the combinations, including the IM medications versus the continuation of the oral medication. So as I said, the dose and frequency of the IM combination therapies that are going to be done in the phase 3 studies have not yet been determined. But they're going to do the same design where they have people achieve suppression first and then switch them to the IM combination therapy. So because 3TC and lopinavir ritonavir work so well, and the question is, will dolutegravir do as well with 3TC? And Annie's question, rilpivirine and dolutegravir, which has not really been addressed yet. And what about dolutegravir monotherapy? So again, to reiterate the key point from this talk, dolutegravir monotherapy is not ready for prime time. But I'll show you some more details. So why would we want to use dolutegravir? So, I have to say that I'm a late adapter in general because I'm very conservative. So that means when patients are likely to be really non-adherent, do I really want to put them on a dolutegravir-based regimen when I know that I have 10 years of experience with a ritonavir boosted PI and then they won't fail? So I'm a late adapter because maybe I'm not pushed against the wall to have to do something for a desperate situation as much. But what we have found is that dolutegravir is dramatically better in terms of the genetic barrier and the potency compared to the first generation drugs. And I imagine there's a lot of providers in the room that have used a lot of dolutegravir in patients whose adherence is suboptimal and that might have failed. But if they didn't receive a first generation integrase, then I don't think anyone has seen a patient develop integrase resistance in their practice. So that's with a lot of patients that are probably at very high risk for non-adherence. And then why does this not happen? So just to remind everyone, this is also what happened with PIs. If you were exposed to a non-boosted PI and you develop mutations, then you were more likely to develop resistance to a ritonavir boosted PI. And similarly, if you're exposed to a first generation integrase inhibitor, you're more likely to develop resistance to a second generation integrase inhibitor. But in the naive trials, which were the single trial, the Spring 2 trial, and the Flamingo trial, no patients have developed dolutegravir resistance. So to remind everyone, the single trial was the Epsicom dolutegravir versus the Atripla, and then Spring 2 was 2 NRTIs with raltegravir versus dolutegravir, and Flamingo was, I think, Truvada FTC with ritonavir darunavir versus dolutegravir. And in none of those patients were failures associated with dolutegravir resistance. And the in vitro explanation for this is that the mutations that are selected for by dolutegravir, the 263 or 118 pathway, lead to dramatically decreased viral fitness. One other thing that's interesting is in that all those naive studies, I think this was really interesting, none of the patients developed any NRTI resistance mutations either. So that suggests that this potency and something about this regimen being so potent that it actually protects the whole regimen. And this is superior to trials with ritonavir boosted PIs. So again, it tells us something about how potent the regimens really are when they're given to naive patients. And so another reason why you might want to study this combination is that it might be very cost effective. So the first study that I think was very well designed as a pilot study of the 3-TC dolutegravir combination was reported, I think, in the fall. And they looked at 20 patients, and they were hepatitis B surface antigen negative, and the CD4 was greater than 200. And they looked at mostly patients with relatively low viral loads. And what they did was they first enrolled 10 patients on the combination of dolutegravir and lamivudine. And they waited until those patients achieved suppression before enrolling the second group. And then they reported the data on all 20 patients where they had data up to week 24. And the planned analysis, the planned study is going to be through week 48. And then one other thing just to mention is that 4 out of the 20 patients had a baseline viral load greater than 100,000. And so the main results of the study are that all 20 patients achieved suppression at week 8, and they all maintained suppression through week 24. So it's a very encouraging result. And they also did some studies on these patients to show that the slope of the virologic drop in these patients was similar in the paddle study as it was for the other naive studies, Spring 1 and Single, where at week 24, the virologic suppression was 2.5 to 2.75 log. So it really confirmed by looking at the slope of the HIV RNA decline that it was a very potent combination. So dolutegravir monotherapy, I only have one slide. And my first comment is the bottom comment, which would our IRB have approved these studies? I think not. But there were 4 observational. I just don't see why you would switch people to dolutegravir monotherapy if you don't even know if 2 drugs work well, and there's so many choices, except to become famous. So 87 patients whose viral load was suppressed for 6 to 9 years. About a quarter of them, this is a summary of all the studies that have been reported to date in a meta-analysis. About a quarter of them had prior integrase use, and the overall virologic failure rate was 8% in the patients who, at the time of virologic failure, a significant number of them developed integrase resistance. And I think of the integrase experienced patients, about 20% had virologic failure. So prior integrase use was a major risk factor for failure with dolutegravir monotherapy. And I think this study was actually really exciting that was recently reported, which is the fact that people are studying this 2-drug combination with 3-TC plus dolutegravir even before we have any large studies to support it. But it's interesting because there was a cost effectiveness analysis from a group in Boston that was reported in CID that compared in the United States the cost effectiveness of 4 regimens, which included no ART, initial 2-drug combination with 3-TC plus dolutegravir, versus a 3-drug induction with 2 nukes plus dolutegravir, and then maintenance dolutegravir, 3-TC plus dolutegravir, versus standard treatment. And they used the manufacturer's cost in the United States for Epsicom as the 3-drug combination. And so it was about $10,000 less per year if you gave the dolutegravir plus 3-TC versus the 3-drug combination. So in their study, what they found was that if 50% of patients in the United States were started on 2 drugs, the cost savings would be $800 million over a 5-year period. And if 50% had an induction maintenance therapy and then switched to dolutegravir, the cost savings would be $500 million. So this is just to say that this is just the beginning of looking at these combinations. So I think Annie, are you finished enrolling, Annie?
Yeah, the study's closing very shortly.
excellent. So there's an ACTG study looking at 3TC plus dolutegravir in treatment-naive patients with 120 patients, an open-label study, and 25% will have a viral load of greater than 100,000. And then there's a European study looking at 3TC plus dolutegravir in suppressed patients. And then I think SWORD1 and SWORD2, Annie, is actually rilpivirine plus dolutegravir, Annie.
What that?
SWORD1 and SWORD2, rilpivirine plus dolutegravir.
All right.
Are you excited?
I'm very excited.
Okay, very good. All right. And then there's going to be a 3TC plus dolutegravir in treatment-naive patients comparing 2 drugs versus 3 drugs. And then there's also going to be a switch study in suppressed patients, large phase 3 studies that will perhaps lead to other co-formulated antiretrovirals that do not include tenofovir or abacavir. So my conclusion slide, which is that I think there are potential reductions in pill burden, cost, toxicity, and preservation of future treatment options, which should make us look at these combinations very seriously. Probably safest both in induction maintenance or switch to combination in suppressed patients, especially, again, my major criteria for a switch to 2 drugs or a less, intense regimen is, has the patient maintained virologic suppression for a long time? Because then most of us are more comfortable. So people might ask to be put on these 1 drug or 2 drug combinations, but if they've not been able to achieve suppression under 3 drug combinations, and it seems like a really bad idea, or if they've received a lot of different regimens and have experienced virologic failure. So to date, we have the best data for 3TC plus lopinavir ritonavir, and we have mixed results for raltegravir plus darunavir. And then the combination that would probably use most frequently now, darunavir plus dolutegravir, we don't really have any data on. And then we have a possibility of a long-acting combination, and that we have a lot of 2-drug combinations that trials are beginning to enroll, and that we should have a lot more data on in the next few months to years. And so the potential limitations of 2-drug combinations is that TAF just came out, and it's so much more benign. Therefore, why do we need to bother doing this? Because it's kind of like maybe TAF is as benign as 3TC. And another thing to be concerned about is there sufficient virologic suppression in all reservoirs, like the lymphoid cells and the CNS, so that when you de-intensify a regimen, do you maintain suppression in all the reservoirs? And as a reminder, you wouldn't de-intensify someone off their tenofovir if they had chronic HBV infection. And that there's even less evidence for patients with bad risk factors like low CD4s or high viral loads. And thank you for your attention. And I want to acknowledge people whose these are people whose slides that I have adapted for my use for this talk, and I'm very appreciative to all of you.